Hello and welcome to today's webinar entitled One HCH Center's Framework for a Safe and Healthy Environment. I'm Michael Durham and I am the moderator for this webinar presented by the National Healthcare for the Homeless Council as part of our spring virtual training, which is supported by the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the final portion reserved for Q&A. If you have questions for the presenter or are experiencing technical issues, please use the chat box below the presentation slides. You may also call the Council's office at 615-226-2292 and ask for Julia. This session is accredited for one continuing medical education credit hour through Vanderbilt University Medical Center. If you do plan on claiming credit, a window will appear about 40 minutes into the presentation with instructions for you to follow. Please note that the text-in code will only be available during the session. Our learning objectives today are that participants will be able to build a framework of action steps to create a safe and healthy HCH environment. That they'll be able to identify 3 to 5 systems or actions to create a safer and trauma-informed environment and be able to name measurable indicators for validating increased safety. Our presenter today is one of my favorite humans, Jennifer Metzler. Jenny is Executive Director of Albuquerque Health Care for the Homeless in New Mexico. She has over 30 years of experience working in community-based organizations dedicated to health, ending homelessness and poverty, and addressing violence against women. Jenny is the current president of the National Health Care for the Homeless Council, as well as an APD Forward Coalition Steering Committee member working on law enforcement reform. She holds a BA in Spanish Latin American Studies from Beloit College and a Master of Public Health from the University of Michigan, and completed the Johnson & Johnson Healthcare Executive Program at the UCLA Anderson School of Management in 2015. And with that, I would like to turn it over to our presenter, Jenny.
Thank you, Michael, and thanks everyone for hopping onto this training today. I always am so thrilled and excited and looking forward to any opportunity to talk with and think through ideas with this incredible community that tunes into the support of the National Healthcare for the Homeless Council. So I just want to pause at the beginning and set some reflection moment focus on the context and the timing of this presentation. When we first decided to do it and we're pulling it together and talking through what that would look like, I think that there had been a lot of gun violence and a lot of consternation about that, which makes this a really, really critical conversation. But I think the most recent events and some of where we're hoping and seeing the national narrative shift have happened much more recently as we were preparing it. So I just want to note that. I also want to say that what we talk about here in our thinking about our campus environment and our services and safety and real healthy, welcoming environments is that we can't ever promise or guarantee that everyone will be safe all the time. And so our approach to this is similar to bloodborne pathogens and universal precautions, which we all know. Our framework is very much about understanding that and understanding anything could happen here, anything could happen at the 7-Eleven while you're picking up a soda, and that we can prepare people and we can have an understanding and some training around preparedness and response, but that being alert and being attuned and preparing people in that way is the best thing that we can do. So our framework and everything I'm going to present today really comes from that conceptual place. Again, there are many, many different things that people can do around safety and around a healthy campus and health services environment for healthcare for the homeless. What I'm going to present today is just what we've done. I am not a law enforcement professional. I am not a clinician. I am not a workforce or workplace safety expert. This is what our organization, Albuquerque Health Care for the Homeless, has done, put in place, and we continue to improve and evolve and grow. I also want to note that healthcare for the homeless in our model is by definition unconventional. So our approaches are not the conventional ways. The settings we work in are not conventional healthcare or other services settings. because of the circumstances of homelessness, which is what defines our response and our model. We're necessarily very person-centered and trauma-informed, and so there's inherently less structure in everything that we do. We work in much more public spaces, which then by definition are much less contained. So this is why this topic is really, really critical. I will really briefly, for those of you who don't know anything about New Mexico or Albuquerque, New Mexico, just give a bit of a sense of place because it's really important. Albuquerque, New Mexico is in a state of about a population of about 1.5 million people, and about a third of those are in our metropolitan area. So we're the economic, the population, and the services center, right at the crossroads of two interstates. We're a border state. We have vast open spaces, very low per capita, throughout New Mexico, and Albuquerque as the largest city still has a real small town kind of rural feel as a result of that. We have, as you can see in the picture, the Sandia Mountains to the east. We have the West Mesa volcanoes to the west, and then we have the Rio Grande, the river that runs through it, and I just love to say that. Albuquerque also has a high poverty rate. It's generally around 20%, and New Mexico has ranked as a state of very few cash resources pretty consistently for a very long time. About 11% of our population is foreign-born, and nearly 30% of households speak a language other than English as the primary language. We're a minority-majority state. Our Republican governor, based on those statistics, pretty much needed to expand Medicaid in 2014, yet the population of New Mexico is still 54% with public health insurance of the insured population. We think that those who experience homelessness on any given night in Albuquerque are about 3,600 individuals, and that is not the formal point-in-time count. That's a different training about the problems with those methodologies. But that's what we've done in our needs assessment by looking at other data, such as public schools and some other places where information is captured. We were one of the 19 original Healthcare for the Homeless pilot grantees with Robert Wood Johnson, the Pew Memorial Trust, in 1985 when this model was being developed. And then we became a federal health center grantee in 1987 when the McKinney Act was passed and the 330H Healthcare for the Homeless program. It wasn't called that then, but was incorporated into the health centers. We're now freestanding. We serve exclusively the homeless population, and we provide very integrated care, as is the model. We do that both here at our central campus near North Downtown in Albuquerque, and also through outreach all over our community. Here are just some pictures so that you can have a sense of our physical space. We have on the left is our clinic for now very, very integrated behavioral health and medical. It's around a central courtyard. There are two other buildings to either side of that. And then with ACA funds, Affordable Care Act monies available to health centers, we were able to build a building across the street. You can see our mobile unit in the top right-hand corner. That's our harm reduction outreach vehicle. And we extended the courtyard, the concept of our campus, across the street and added 8,600 square feet, which has presented some new challenges in and of itself. The outside of that building is right in the middle from our meme from our Know Your Rights forum that we did recently. And then I also have a picture in the lower right hand of our Art Street Community Arts Studio. So it's an example of how our campus flows and also some of our low demand entry thresholds and community gathering spaces. So that's our context. This has always been really important to us as Healthcare for the Homeless. Our outreach teams on the street have protocols for when they shut down, when it doesn't feel safe. We have always had some sort of internal staffing response to crisis or escalation. We've done training. So there were tensions, there were a lot of questions around that prior to a somewhat pivotal moment for us in April of 2016, which was 6 months after we opened our resource center across the street. Also in just a world context as well of a lot of increasing stressors. And so we would talk about it, and sometimes it would cycle. Staff would express feeling unsafe. We would have incidents, of drug dealers coming by. They would move through. We would have things that felt like they jeopardized the safety and the environment here on campus up until then. We didn't have an overall framework, and there were some things. We would add things sort of ad hoc to respond. In April 2016, we hit a very different moment in terms of how it felt, how people perceived their safety, both staff and clients. We had many, many first responder calls, our internal first responders, to de-escalate on any given day. We did have some police presence here and people being arrested. We're pretty certain there were undercover officers working in our campus and around the neighborhood. There was a lot of drug dealing. There was a lot of very overt sort of turf competition. We added that street between buildings. This was also happening in our city and moving around our city, but we created almost a whole other space for some of that to happen. There were a lot of cars through. There were weapons seen. Staff were being threatened in very, very specific ways. We had an on and off, again, security company that we had hired in a sort of reactive way a year or so prior, and they had a really intense approach to providing security, and we had some very frightening incidents between security guards and our clients that felt out of our control, and we had not really done our due diligence on that security company. That all came to a head. I had concern with several of our senior managers and leadership that one of our staff was not going to make it home to their families on any given night. It was that frightening, so we knew we had to do something different. I'm going to talk through what resulted from that, but that was really a moment where we realized some things were beyond what we were able to handle and that we needed to approach it differently. We had to get very clear about it, more systematic, and we had to reach out to other stakeholders, such as law enforcement, some of our neighbors and partners. So I want to present some today on what the impact of that has been and how we framed it up. So there is a document that outlines the next 4 or 5 slides in one place, and it's our framework, what we created that we live by, that refines, that we can refine, and that guides us on everything from prevention through actual crisis intervention on our campus, what the activities are, how we can monitor those, and what the elements are, which I'll share with you today. But it starts from very routine things that we do for prevention every day. We all engage and we greet people. Really, really simple things that work. We get a little more proactive and assertive about the engagement, a little more intentional prevention. We begin to do intervention here, what we can handle here, and then crisis intervention at that other end of the continuum is usually with some form of external first responder, including law enforcement. So in the document that says HCH framework, you'll see directly verbatim these next few slides. So what we do for the FAR prevention end, very broadly, as I said, we say hello. Everyone here, we have 107 employees. Everyone is an engagement person. We all engage all the time. Our campus is small enough that we move around a lot. We say hello. We ask people how they're doing. And then if we say, hey, how's it going, we're prepared, as you all know, to sit down and listen and not just blow through like we didn't really mean it. So we're sincere. We direct and help. Anyone can help navigate, help get people to the right place, whatever they're looking for on any given day. We have signage that helps people with wayfinding that we get feedback from consumers on, whether that's helpful or confusing. We have shaded space, again, in our central courtyard. It's really critical to the environment we create here, and our consumers said it was too hot. We live in the high desert. It gets really, really hot here in the summertime, and so we planted trees, provide very comfortable shaded space. We wear our badges. It's a simple thing. I was one of the worst on not doing that consistently, but people know I work here. They know I'm a resource. They can ask who I am, and I can be accountable. And then we also, in that, include people in different ways that everyone is an owner of the space here. We added the 8,600 square feet to our resource center that is populated with community partners who are housing and voter registration and traumatic brain injury support and managed care organizations for Medicaid. They're care coordinators. We really try to saturate that space with outstation resources so that people can feel like it's rich and for them. I'll talk a little bit about the built environment there. And then we also did our due diligence. We contracted a new high-quality security company where we have a lot of say, and they work closely with us. We get a little more proactive, so we do training for all of our employees and for our security guards on trauma-informed care. I have a list of this a little bit later, the specific trainings everybody's required to do when they come in, and then on every year or two, depending on the training. We are a little more assertive about problem solving, really calming engagement, that people know that our managers, everyone is here to try to resolve their concerns or whatever is causing them consternation at any given time. We do a lot of, I'll talk to someone and say, let me get you over to the dental clinic so you can talk to Christina and see if Charlene is, that we make it, we really do those warm handoffs just as part of the flow here. We provide services. We'll go out into the courtyard. Our medical providers will go to a triage room over in the resource center, and social services folks will come over to the medical clinic, that we really try to be nimble in providing the services in a no wrong door way. We talk to people. Waiting areas go out into the courtyard space. We have sort of pause places. Our resource center was designed where people don't have to sit right in the midst of everything. They can go and sit off kind of in a corner beside a stairwell and not be super saturated with people and activity. We have a lot of relational space. We understand that the experience of homelessness will generate transactions. So someone swapping their bus pass for a cigarette or whatever that survival is, we don't need to police that. There's some other behaviors that we're more concerned about in terms of safety. We have client rights and responsibilities posted everywhere, a formal grievance policy. We work with our contiguous and other neighbors, so we'll do safe syringe disposal. We'll go into the alleyways before we open in the morning, remind people the resource center has showers, check in with them, meet with them one-on-one, and really try to do that very proactively. We work with law enforcement and community policing right in this area. We have added since April 2016 2 engagement specialists. When we conceived of that, I called them the vibe keepers. It was when we were coming up with this framework document. But just really people to be out there, to be tuned in, what's going on, who do people need to see. They might navigate, but they don't get super involved in navigation or client advocacy. We have people who do that. They're just out there to be human kiosks, to welcome people, to see what's going on with them, to connect with the managers or the security or others, to just kind of keep the flow outside of our building space and services space moving. So there's a lot of outreach skills. That person is a part of our harm reduction outreach team, but based here. There are actually 2 positions. And then we do data. We monitor all incidents. We've gotten much better at documenting those. And then we have a whole tiered structure for accountability and reporting and analysis and investigation and performance improvement around that and looking at our incidents. When we get to a point where someone is beginning to escalate or we think that there's an emerging crisis, we have an internal first responders team. They're trained people led primarily by our social services program manager and behavioral health clinical director. Some of those are administrative staff. Some people just have a knack. Some have lived experience, but we train them. Some come with high levels of training. Folks that are out, we write down license plate numbers when dealing or other activities for people who are not eligible for our services and are not going to come here, or people who are eligible for our services and are somehow engaged, again, in transaction that may be illegal. When that starts to pick up, we stop it, and we work with the police department on that. I think confront here, nosing around, asking questions, I think confront is probably the wrong word in this place. But, if something's going on or we ask, what's going on? We use the skills we're trained to in interacting with people, in motivational interviewing, to just find out what's going on if we suspect something is about to happen or go on. And then we request different behaviors. This is where this document lives. It has an asterisk, and what that means is that's an area that maybe we can improve upon. So we're asking ourselves, are we good enough at establishing expectations for behavioral norms on this space here? So that's pending, and that's how this is a living plan for us in document. I'll probably say 8 times during the presentation that we do de-escalation training for all of our employees, but it's really, really important. We have a physical presence of many staff all over our campus. The security is very present. They work with staff in that, and the security company, they have to move around to these little technology stamp things, these round things around our campus where they have to like swipe in. And that goes back to the company so that they know that those security guards are moving around campus, checking things out and engaging people. We have a therapist for the day. We will ask people to leave for the day. We don't ban people. We don't for life. We might do a separation. We have a process for that, but we really, we want people to stay engaged in services. And we're often the last resort. So, but we can, if someone's behaviors are creating an unsafe environment, then we can ask them to leave for the day, and any staff person can do that. Sometimes our psych staff will work with the crisis intervention team of APD if someone really is in need of some inpatient time in a psychiatric facility, then they can do the certificates. And we have things all kinds of codes, including a code blue for our medical teams. And last, if we need to intervene and something is beyond us and we can't de-escalate and there's a real crisis or a safety issue, we know when something becomes a law enforcement issue. So we'll call the crisis intervention team, 911, the non-emergency line. We might implement a separation. We have done restraining orders and criminal trespass. We have done maybe one evacuation that I can remember, like when there's a called-in bomb threat. We do lockdowns, but we do lockdown and then we continue providing services to the people that are in the building. We don't lock everything down and stop if there's just someone who's escalated. And our security can intervene, although I'll talk more about security. They don't have weapons and they're not hands-on. So the process for how we got there and created that framework is we got all of our supervisors, our leadership team together, which is 20-some people. We did and discussed what we had in this framework. We looked at workplace and industry practices as best we could get them about what truly makes a workplace safe. We talked to law enforcement, we talked to our partners, we talked to other service providers, we talked to other healthcare providers, and we use a values-based decision-making model that is very explicit, and I want to plug it. There's an outline with the reference also in the handout in the files. Joan Gibson and Mark Bennett are local consultants and bioethicists and attorneys here in New Mexico, and they've trained our leadership staff on their methods. So we've now internalized that. I now do the training. The staff practice as new leaders come on, and we use this ongoing when we talk about this because this is so perception can be so loaded and opinions can be really different and polarizing when we talk about this. So that was our process. I'll talk a little bit more about some of the stakeholders and the structure to how we got here. So I think a lot in terms of in sharing this kind of thing, essential elements. What were the essential elements that you all might consider might already be applying in your workplaces and your organizations and programs, but just running through how this was systematic. We didn't just sit down and come up with a one-pager. The first thing that we did, we elevated in April 2016, at that pivotal moment, we elevated this issue institutionally. So we created an organization-wide safety initiative that was led by senior management, but that everyone had input the whole way through. Research. You do research. We looked at recommended practices. We reached out to other healthcare for the homeless organizations, in our case through the council contacts and our peers, talked to others about what they were doing, looked for the evidence. And here I just want to pause. As the executive director of this organization, having been here for a really long time, I'm an old outreach worker. So I know about safety, but I don't necessarily know, what hospital. I haven't worked in a large hospital. I don't know a large manufacturing plant. I think there's a lot of information there that we need to look to. But when staff come to me and say they don't feel safe, that's very important to me. Over the years, as I said, it would sort of cycle. We've had people, for example, suggest that we put metal detectors at the door to our clinic. Then they would feel safe. As the executive director and leader of this organization, I can't do something that will make you feel safe because you're in front of me and you're concerned and I care about you. I care about our workers and our clients and our neighbors. I can't do something that will make you feel safe if it won't keep you safe. And so that's where we began to apply. That's the lens that we began to hold up to all the suggestions that were coming through. And that's why knowing what the recommended and the evidence-based practices are is so important. Because if we think again about universal precautions and preparing people, if I do something, put up something or do something that makes people feel as if they're safe and they let their guard down and they stop practicing what they've been trained and taught in our protocols, then shame on me. And then I'm really worried about people and their safety. So that's kind of my stump speech on this one, but this is a little later I'll talk about the tensions inherent in this. And this was one that was really, really, really hard to have people saying they don't feel safe and wanting to do something, but needing to back up and do the right thing. The other thing is create a plan. Do a written plan. Whatever format, use our format, don't use our format, do something else, but to have a written plan that you can refer back to and monitor as with anything. Develop that with the critical stakeholders and share and communicate it widely. Another essential element, this is the National Healthcare for the Homeless Council. This is absolutely about consumer, client, participant input. Hear from the people with lived experience who are coming here for services. We have a client leadership committee of our board of directors. It's led by elected board members with lived experience, and so they talk about it as a standing item. They talk about this all the time. They do focus discussions, surveys. On a monthly basis, we can get input and keep track of it, and they helped us develop that framework. As I said, Art Street, our community art studio, also has an advisory council that meets weekly. They're in one of our low-demand, very open gathering spaces, and so they give a lot of input. Client experience surveys, focus groups. Sometimes one of our consumer leaders will just go out in the courtyard and start talking to people, and it turns into a little plaza gathering for input and conversation. It's also important to invite people who are not accessing services. So our board of directors, in thinking this through in 2016 and collecting information and research, had 2 panels at their meetings as part of their governance and planning sessions, agenda items. And one was our friends from the Transgender Resource Center of New Mexico, who talked about, looked at our space, sort of audited our space, talked about the experience for trans people coming into this space. We also had women who were exiting incarceration, who had children, who were often struggling with substance use and mental health disorders, who were at a peer organization crossroads for women, and it was hard for a lot of those women to come here for services. So they sat in a panel and spoke directly to our board of directors. Structure, having clear roles and a clear structure is an essential element of this framework. So we work through multiple board committees. Our executive committee looks at incident reports on a quarterly basis. Our finance committee looks at risk overall and where we're investing money in mitigating or reducing risk. Our program review looks at our philosophy of care and how this is reflected throughout all of our programs. They all meet on a monthly basis, and I mentioned the client leadership committee. Our senior management serves as our compliance committee, so we're the ones that are looking at every single incident, making sure that it's addressed, seeing where trends are, and doing evaluation around what's happening on our campus. We have a safety committee. It's cross-department, made up of managers. They meet monthly. They look at everything from OSHA to a health and safety campus environment. We have our internal first responders, which I've talked about. We've changed our separation review to client behavior review committee and restructured it some so that we're certain that we are consistent and we're certain that we are very focused on the person and their experience. I'll give a little example in a couple minutes that shows where sometimes it can be hard to know what to do when a client has had a bad day and others were rattled by it. Our security contract, we have a new one. We have a company that has a deep bench. They have well-trained people. If someone isn't working well, within 30 minutes they can have a replacement here. They wear khaki uniforms rather than black militarized uniforms. They don't carry weapons or mace, nothing. And they engage with clients. They have, I think, 99 protocols on how they operate, and we got to make calls on all of that when we finalized our contract. So we really did our due diligence. So security can work with this and serve a real specific role. They can ask people to leave, but they don't ask anyone to leave without conferring with our managers. And then the daily we work in a neighborhood, and so we have to look past our campus, and we work with all of these different entities very assertively on a regular basis. Codifying, another essential element is to codify these things, put policies and procedures in place, make sure that there are mechanisms for formal mechanisms for everything from client complaints, conversations with managers, availability, feedback, that we're really interested in resolving their issues, all the way to a formal grievance, which is a policy. But this in itself can prevent escalation. We have all our crisis codes in policy format. They're listed there. We do trainings for staff, as I've mentioned. It also includes on our philosophy of care, trauma-informed care, harm reduction, engagement practices, and an emphasis on cultural humility, anti-oppression frameworks, and understanding power, and gender and race and other equity. And we practice. We do drills. Sometimes it's really feels disruptive to do drills. If we do a fire drill, for example, and we move clients out of a space. We did one recently, and I saw some of our medical assistants escorting a gentleman who was had oxygen and was having a hard time walking, and I felt horrible when they pulled people out of showers. But that muscle memory is really important so that when the moment comes that we need to do something, we're prepared. The other is to really treat this like a performance improvement, to use the methods for tracking, for communicating transparently with people so that it doesn't cycle up. And we hear about safety or people feeling unsafe, that we really are able to have some feedback loops and some information and some data that we're looking at. And I'll talk a little bit about indicators. And then there's the issue. Sometimes we can do a lot to the built environment. Like we built a whole new building, which was great. It's open. It's got a lot of light. It's got a lot of windows, which our custodial staff just love. But it's really a different environment, and our incidents there have actually gone down significantly, and we were able to create that. Sometimes we can do renovations. Sometimes it's about what you decide on flow. Having any place that can be a community gathering, interaction, good relational space is important. We also, the openness I talked about also includes, for example, at our front desk, taking down barriers. When someone comes in and sees a glass barrier to our receptionist, it felt like a message. And so we took those down and promised that we would put them back up if it was problematic. And this was hard for people. This was a bit of a leap. But we also moved the desks back so that the receptionists had a little more distance, but they're still eye-to-eye and open with the staff. We don't do a lot of roped lines. We're all trying to figure out what to do with the lines, right? But we don't rope them and contain them like an airport because we don't want people to feel really controlled and constrained in a way that could stress them. So I'm happy to say those glass barriers have been down for over a year, and it's fine. As I said, anything can happen at any time. We have a very nimble engagement team concept, as I talked about some, and we're looking at, in addition to the vibe keepers or the engagement specialists, to pull our client advocates, our community health workers, and navigators together, that they would be the lead in anchoring the space as the rest of us move through it in engagement. So they would model, they could train, and they can unpack it a little bit for people who might be a little uncomfortable with that kind of engagement. I think also I'm going to talk a little bit about the tensions inherent in this framework and what we've experienced. It's really important to have critical dialogue, to have deep conversations, to be willing to do that, to be very deliberate, reflective. Like we can react, we can be proactive and out in front, which sometimes becomes a form of reaction. We can be inactive, opt to not do anything, active. But whatever we do, we need to reflect on it. We need to be deliberate. We need to define what we're doing. We need to build agreement, have conversations, including the ones that can be kind of disturbing, because that's how we'll pull together and make change and lead change to a healthier environment for everyone. The indicators since April 2016 that we track and that let us know that this is a safer place are particularly incident reports. So 6 months after enhancing this framework and working systematically like this, we reduced our internal first responders calls by half. It was pretty astounding, and we have maintained that for over a year. It plateaued there. So we feel that we're doing something right. It feels very different here, and this is a very measurable indicator. We also thought, with all the sort of sense of chaos and the people here, that we thought we were going to lose numbers for a while and serve fewer people because people would be unsure if there were police arrests here of drug dealers, and what did that mean, and whose side were we on? And so we had a lot of preconceived ideas about that. But what actually happened was by the end of 2016, we increased our client users on our Uniform Data System report by almost 13%. So what happened was we created access because we removed the gauntlet, and people were actually able to get to us here at our site. And then we also look at patient-client satisfaction indicators, and we have the monthly vibe check and check-in with our client leadership committee. Neighbors have given us, through formal and informal meetings, have given us quite a bit of feedback about how it feels better, how they feel considered, how they really appreciate us in our leadership in this. The police department looks at the calls for service in this neighborhood, and they do heat mapping. That's actually very interesting. And we thought that we were probably one of the main places where they had the most calls for service, and it was actually about 6 blocks away by a courthouse. So that was another indicator for us. And accountability, our social contract with the community to realize that we work in community and we're all about community. We also get calls from city council staff when they get calls from constituents who appreciate being able to look to. We might go out and do trainings or check in on someone that they're concerned about who's camping in their neighborhood or clean up syringes, but that's also part of the safety ethos. So I'll touch briefly on tensions, and then I want to give one example of this, and then questions and answers, because I would really like to hear what people might be thinking. As I talk about some of the tensions inherent in this work, again, healthcare for the homeless is unconventional, so there are going to be tensions. I just always want to sort of place our thoughts in the importance of empathy, because that's what allows us to have some of these conversations, particularly when we're talking about people's feelings of safety, which is so basic. That's our art studio. So something that I've been having with some of our managers we've started to do is, rather than talking about either or one thing versus another thing, we're talking about the ands, that we live in the reality of these tensions, and we can pick one pole or the other when conversations become sort of polarized, but really reality is somewhere in the middle. So we have to be able to hold these tensions, and these are some of the ones. I don't claim to have had this all figured out in our organization, but we do come up against this, particularly when talking about safety. One is individual perception of safety and defining collective safety and what's good for the good of the common and all the people who make up that common or that community. What could happen and what actually has happened. So we could do the what coulds forever because there are a lot of them, but when we debrief, we have to look at what worked. Not just what went wrong, but what worked, and not just what could have happened, but what actually did happen. So our debriefs are focused more in that language now. We have this apparent dichotomy about a welcome and opening environment and then trying to ensure safety, which often has a sense of a lot of controls. We are, again, by definition and training, those of us drawn to this work, very empathic, and we work on empathy. And so boundaries and rules and structure feel like they could contradict that, but it has to be an and. Now, this is a can of worms, but I'm going to open it up because we're talking about it here. I think we're talking a lot about embracing being trauma-informed organizations. We've gone beyond just care to being trauma-informed organizations. And that is certainly for clients, the people that we serve, and for the staff who make up our workforce, and for other community members, including our neighbors, law enforcement, et cetera. But I think there are varying understandings of what that means and how it's actually accomplished. So we're jumping in to talking a lot about that so that it doesn't become either or, and it really does remain inextricably linked, that all these people, the good of the common is about all of these people. We have a question about hands-on or hands-off. We do not do takedowns. We have some staff who have been trained in inpatient facilities who are former law enforcement, former military, but our security doesn't do any hands-on. We don't do any of that. There's concern that maybe while we're hands-off waiting for police to arrive, that clients who are in a physical altercation are actually hurting one another, and we're allowing that to happen. We've had to have long conversations about this, but we have maintained until now that we're hands-off. Oops. I think another thing that is really important but sort of confusing is to understand that one person can hold two or more perspectives on a particular related issue, and those might change over time. So, for example, when the women of Crossroads came and talked to our board of directors, and I think the National Consumer Advisory Board of the Council actually found this in their national research and recommendations as well. We asked, do the security on campus and uniforms or law enforcement getting a cup of coffee before they head out on their beat in the morning in uniform, does that trigger you? And the answer was absolutely. We've had horrible experiences with law enforcement. We've been in jail. Uniforms trigger us, and they make us feel safe. So I think that was something that's been really enlightening for us. I think there are all kinds of identity, like I said. Should we have uniformed police here, but we're a service organization? You know, these questions that rise. I think flexibility and consistency, which fits with some of the structure. And then leadership and uncertainty, just, you know, what I was talking about before of like really wanting to do the right thing. So the work going forward, we just have to keep doing it well. We have to keep monitoring it. We have to continue to get feedback. We have to keep expanding based on what we learn from others and from the evidence and the growing body of conversation and experience around this. We have to celebrate safety, what went right, as I said. And then we need to share and talk about these essential elements with everyone. I have one example, but I think what I might do is go ahead and recommend these documents and references. The National Consumer Advisory Board, as I mentioned, did both some research and then also some recommendations that I think would be that have been so useful for us, and I think would be great to share with all the world working with this population and struggling with these issues. I think at that I might toss it back to Michael and see if there are any questions in the remaining time, and then I can give a specific example of some of this if there's any time remaining, but I want to hear questions for sure.
Okay, thank you, Jenny. This has been really meaningful and interesting to me, and you've done really impressive work at your organization. I do want to remind everybody to put your questions in the text box beneath the slides. And just another reminder that if you do plan on claiming CME credit, there is a pod on your screen to the right of the slides. You need to copy that information now because that code will disappear at the conclusion of this webinar, and you must use the text-in instructions within 24 hours. So just a reminder about that. So I've got a question, Jenny, in the box here about whether you have recommendations of how to identify security firms that are willing to function within a trauma-informed care model, or whether they are already. Can you speak to how that works when security is contractors and not employees?
Sure. And we thought about whether or not, and talked to people about whether we should have in-house security and employees, but we just felt like that was not our expertise. So really clear distinctions about roles. We also, there were many people in reaching out. So we reach out, talk to people. Who's your security company? How's that work for you? And there were people that said, that's not what security does. You will never find a security company that's willing to do that. So we researched it. We interviewed them. The safety committee with the managers from different departments that I talked about interviewed the companies. We had them come down on site and walk through, and we just really challenged them, questioned them. We were, again, very, very rigorous in our due diligence, and just put it out front. And actually, this isn't like NPR, right? So I can say that Securitas is our company. And we had our criteria, and they were willing to go with it. And philosophically, their company can do everything from real extreme, weapons and armored cars. I don't know enough about the industry to, really, philosophically, they preferred to de-escalate before they go to those extremes. And so that was their company philosophy, and we got that pretty early on. And then the very specific things they were willing to do with us, like we picked what kind of uniforms the security guards wear. We've had security guards who are of every gender identity. We've had bicultural, bilingual speakers who engage with our clients in Diné or Navajo or Spanish, and that's just been really incredible. So
I'm curious, do you think that you had more success when you had, or fewer incidents, however you measured success, when you had security that were minorities, gender minorities, or racial minorities? Do you think that makes a tangible difference?
That's an excellent question. And I would, in my heart and soul and every cell and every experience think, yes, if the data don't show it, it's still a really important thing to do. But that would be something that maybe we could go back and disaggregate. That's a really great question, Michael.
I have a couple more questions, and again, everybody, please use the chat box to engage with Jenny. I wonder if you can talk more specifically about the presence of firearms or even mace. You said that the security don't have mace. I think it's my perception from working with other health centers that they do have armed security, and can you kind of confront the rationale just because we have health centers of all different types represented in the group? Can you kind of confront that, please?
Our feeling is that when people have weapons of any kind, they behave differently. And it could be letting their guard down, not practicing the kind of, verbal judo, I think they call it, some people call it, but the de-escalation, the engagement, and that if there are weapons here, our feeling is they're likely to be used. Now, do the people who come here for services have knives? Do they have, who knows what they have in their packs? Survival, we all know survival on the streets is about a lot of trauma, a lot of physical attacks and violent victimization. There's actually another really great paper from the Council of National Consumer Advisory Board on that. So we recognize that, and it's not that there aren't weapons on campus, but we just think that if our staff or our security guards have them, they're more likely to use them sooner, and we know that behavior changes, and that's just too frightening for us.
Yeah, thank you. Jennifer asks how you manage communicating incident information to all staff versus unnecessary exposure.
What does unnecessary exposure mean?
I don't know.
Like too much information, maybe? Jennifer, can you type? I will. So what we do is, as I said, the incidents come in, and staff actually are the ones, any staff person will do, we have an electronic format for reporting incidents, and we've encouraged people to report, when in doubt, report. More broadly, at least we'll have the information. And then one of our senior managers who's responsible for compliance and all incident reporting with her team goes through those if there needs to be an investigation or different staff teams that made the report or were part of the experience. So individuals more immediately in real time who are engaged will be brought in for a conversation about what happened to see if we need to address anything. And then every quarter, senior managers look at every single one of those to make sure everything was addressed, to see if we need new policies, to see if we've taken care of things, or if we can set it aside and then begin to just trend it. And then we do quarterly trending reports about where incidents happened, what kind of incident it was, whether it's a HIPAA compliance or whether it was some violent thing that happened that the first responders had to come or the crisis intervention team was called. And so we do analysis of that. That goes to the executive committee, and it's vetted there, and then it goes directly to our board of directors, which includes consumers. All managers are at all the board meetings. It goes to the entire leadership team so that they can see that, share that with the trends with their teams. So it's ongoing, and then it's also sort of pulling it up to see what's emerging that we should pay attention to. Yeah, and that's how people don't get too much. Right. Thank you, Jennifer. Yeah, people don't get too much. We don't share everything all the time with everyone.
Right. Okay, thank you. I'd like you to talk a little bit more about values-based decision-making in this context, and maybe if there's an example that kind of demonstrates how that framework differs from some other decision-making framework.
Well, I think, yeah, the thing that we have really come to embrace and that I love about this framework is that it considers what is important to everyone. So value is really what's important to you. What do you value? What's important? What matters? And it gives everyone in the room an opportunity to give input and to state what's important to them and why. So the other thing, it's important that there be enough information and that it be transparent around decision making around these things and that that's communicated. So this particular process starts with clearly identifying a decision maker. How many times have organizations been cryptic about where a decision happened, or and the narrative that starts with that just causes a lot of distress. So for example, if I'm going to make a decision around a metal detector in our clinic doorway, then I identify myself as a decision maker. And if I'm uncertain about it, or the research doesn't really tell me, and people are very concerned, then I get whoever will inform my decision in a room. I say, we need to decide whether we're going to do this or not. There's been a suggestion, or we have a decision in front of us. We go around the room. We say, what's important to everyone in this room, top of mind. Then we say, what's important to other stakeholders who are not in the room. Let's exhaust that. So we're not just looking at whoever happens to be in the room. And then we go through and we say, of these, everyone gets to do an advocacy round. This is the most important to me. And my job as decision maker is to listen to that and to really hear. So everyone feels respected and valued, but they know that ultimately I'm going to make that decision. And then at the end, I pick which of those values, which of those lenses are the most important ones for making a really good decision that's informed and acknowledging what was important to people. And then at the end, the communication out in this process is one of the most valuable things, because I then have to communicate to the community or the group or whichever stakeholders what the decision was, why I chose the frame or the lens that I chose for making that decision, what values rose, and the downside of that. That something that was really important to someone in the room did not get considered, but I listened. It just really, it's a way of building trust. It's a way of making good decisions. It's a way of making sure decision makers listen, that they're accountable and transparent. And so that's why we like this. So we decided not to put in metal detectors. And sometimes we do this in 90 seconds. Sometimes we could take 90 days. It just, you can work it either way. But mostly I've been doing it for long enough here that I've internalized it. And so I can do it kind of on the fly. So every decision it goes through that process for me, and it holds me accountable.
Yeah, thank you. Another question here. When I talk to health centers, I've found different approaches to whether they allow clients to spend time in the clinic when they're not there for an appointment. And this is sort of related to the security, the safety conversation. How does your health center approach that, or do you have recommendations around that?
I think, again, the built environment is really important there. We used to have a medical clinic in one space, and then we had a behavioral health drop-in center 3 blocks away, a dental clinic 10 blocks away. We were able to centralize our campus in the late 90s. And we have built out from here. So we have gathering spaces that we've built. We have, when Art Street is open, we have the community art studio. So people might be waiting for a dental appointment and participating in the studio making art. We have our resource center, which has been huge. It was a tiny little corner of one building that was a drop-in center that stressed everyone out, and we added 8,600 square feet, all our social services staff, outreach enrollment workers, client advocates, community health workers, case managers, and their managers are over there. And so you can get on a kiosk in a portal and check your VA or your Medicaid accounts or your SNAP benefits, anything related to your health and well-being in terms of, again, resources. You have access to a computer there. We have a couple showers. We're not the shower place, but we have a couple showers and restrooms. And we have a coffee bar, so it's self-serve coffee. It's just like I have full insurance. If I go visit a family member at a major hospital with patient-centered medical homes now, I get snacks and tea and puzzles and all kinds of stuff. So we felt that was really important here, that people could have the dignity of pouring themselves their own coffee from the coffee bar. So we have places on our campus while people are waiting for appointments or seeking services or just, we engage people. So we're not a day shelter. We're not a meal site. So people do hang out here, but we engage them while they're here. We do it very assertively. We don't sit planted in a chair while people hang out and drink coffee. I mean, we don't harass people, but we really work to engage because we have resources and services to offer. So it's a balance for us, but we've been able to create space. If you don't have space to do that, I don't know that I have a good answer around that. That's what we used to experience, and we were sort of locked into that. We were able to change it.
We don't have any remaining questions in the chat box. I think you said you had an example you wanted to conclude with.
Sure. So when we were first preparing for this and I was talking this through with council staff, we had just experienced a couple months ago an example of everything we had in place and what was upsetting for some people and of concern for some staff people, but also worked where no one got hurt. We had a gentleman come into our resource center, and because of some mental health issues, he was having a tough day and somewhat his behaviors were escalating, and he was very distressed, and he was asked to leave for the day by the staff. He came back, and a couple weeks later, there was an incident with a security guard and someone who was locked in one of the showers or bathrooms, and it got a little busy, and it triggered him back to that first moment where he himself had been escalated and asked to leave, even though he was not at all a part of that. Staff noted it and saw it, and his behavior changed some, and then they asked that he leave the resource center. It was getting very disruptive. And the security guard did not communicate, and the staff did not communicate across the street. So he came into our courtyard, walked into our medical clinic, went up to a nurse who was triaging, and she said, "We can't see you right now." She was very, very busy, and she walked away. That triggered him. He went to the reception desk and was further triggered there and beginning to escalate, and jumped the reception desk, got back into the medical records secluded area, and got through a fob door, which scared everyone. Our first responders were called. They came in. His therapist was part of that team and really doing a good job at calming him down. And they were about to get him out of the restricted area, and two people didn't look through the window, burst through the door, startled him again, and he ran out, jumped the desk again, and went out and didn't come back. Then there were a group of staff that were very upset by that, who made a decision to ban him, which we don't really do, but through our separation process. So it went the whole way through. When we went back and looked at that and investigated, there were so many points that we missed, even with all these things in place, where we could have communicated better, we could have really understood what he was experiencing over time and across our space. So we debriefed and we broke that down. In the end, no one got hurt. He wasn't harmed, and all he was ever saying was, "Please don't touch me." He didn't threaten anyone. He didn't hurt anyone. He was upset, and all he was saying was, "Please don't touch me." So we also looked at what worked in that. We did not ban him for a year. We revamped our process on separation to make sure that it was very consistent and very person-centered and trauma-informed in that way, because I think that's a very good example of where we can miss things or we can work in a framework to be more seamless so that everyone's health and safety and well-being and experience here is a good one.
Thank you for sharing that. That pulls everything together really nicely, I think. We are about to conclude, and I want to thank everybody for participating in the webinar today. A link to the archive presentation will be available on our website, nhchc.org, at the conclusion of the spring virtual training. I want to remind you one more time to copy the instructions in the CME information pod on your screen, because that will disappear in just a moment, and you need to use the text-in process within 24 hours. When we close the webinar, a brief survey will appear in your browser, and we really ask you to complete that survey. And we want to thank you for your time today, and thank you to Jenny for your presentation. This webinar is now closed.